Okay, so let's start our webinar. It's already the time to start it. And hello, everyone. Welcome to the Wisconsin Global Dental College webinar. And it's our great honor to invite Dr. Bulat Tuyakov to be as the speaker of this webinar to share with us about his experience and knowledge about regional anesthesia. And also it's our honor to have our Wisconsin International Marketing Manager, Charlie, as the moderator of this webinar. So let's welcome Charlie to introduce Dr. Bulat Tuyakov, please. Thank you.
Thank you, Olga, for introducing me. Hello, everyone. Good evening. It's my great pleasure and very honor to introduce our important speaker, Dr. Tuyakov. He works in WSS Hospital, Olsztyn, Poland, as the head of Department of Anesthesiology and Intensive Care, and as a tutor in College Medical Warmia and Missouri University. In 1988, he graduated from Medical Academy in Karaganda, Kazakhstan, and gained his medical degree. In 1999, he received his postgraduate training in anesthesia and intensive care in Kazakhstan and Poland. Dr. Tuyakov became a consultant anesthesiologist. In 2012, he successfully passed European Diploma of Regional Anesthesia and Acute Pain Medicine EDRA diploma and was awarded PhD in 2017. He completed EDRA instructor course in 2017. So currently his educational activity includes participation in the UGRA workshops, congresses in the Poland and abroad. He takes part in the CEA, European Society of Anesthesiology courses, congresses, workshops in the Ukraine, Kazakhstan, Moldova, Belarus, Russia as a speaker. So Dr. Tuyakov professional interests are centered on regional anesthesia techniques and transcranial Doppler. Moreover, he is the author and co-author the publications in the Polish and foreign anesthesiological journals. So let's welcome Dr. Tuyakov to deliver his speech today on regional anesthesia for hip and knee arthroplasty, different options, different blocks. So please.
Okay, let's start.
Let's start.
Your nice introduction. First of all, I would like to thank Visonic for invitation. My name is Bulat Tuyakov. I work in the Polish city where have lived very famous medieval scientist Nicolaus Copernic. What will we talk about? Today we will talk about regional anesthesia for hip and knee arthroplasty. We will discuss about post-operative regional anesthesia, this kind of surgeries. We know that total joint arthroplasty are among the most common surgical procedures. It's expected that the number of these procedures will increase until 2050s. In the meantime, we know that the using of peripheral nerve block have been increasing. In the meantime, we use the opioids very rarely. Today, anesthesiologists have chosen more selective block, because selective block is block with good sensor block without motor block. We this kind of blocks as a motor sparing analgesia. This is a good example of this kind of concept when for the total knee arthroplasty we use more distal, and we should know about origin of pain after we should have the knowledge about dermatomes, myotomes, osteotomes, and innervation of hip joint. We should take into account what kind of surgical approach will use our surgeon, and what kind of cutting and what kind of part hip capsule will open. Summarizing, the part of hip joint is innervated by joint branches of femoral nerve, obturator nerve, and accessor obturator nerve, and posterior capsule of hip joint is innervated by the branches sciatic nerve. Our old strategy for this kind of surgeries. 2 decades ago, we had used a posterior lumbar plexus block as a first choice after total hip arthroplasty. We know that lumbar plexus block is much better according to opioid consumption, and lumbar plexus block with posterior approach, we can based on the fact that lumbar plexus lies into psoas muscle 2 centimeters anteriorly to transverse process L4 or L3. And the distance from lumbar plexus and transverse process is independent from weight, sex, and the distance is approximately 2 centimeters. And at the beginning of ultrasound guidance era, the anesthesiologists had started used ultrasound as an assisted guided method for the identification only transverse process, and then they can measure the distance from skin to the lumbar plexus, from transverse process to the lumbar plexus. The current approach was the first approach in the real time. The probe was applied in the scan, and we can identify transversus process, psoas muscle, and what very important, identify a retroperitoneal space with kidney. But unfortunately, posterior lumbar plexus approach is not easy block. A retroperitoneal hematoma was described as a dramatic complication, and we on this picture you can see how close the kidney lies. What is the short distance from the lumbar plexus to kidney? And in the last years, Shamrock approach was proposed as a good method for the identification lumbar plexus. Shamrock approach. This is we can see as a some structures as a shamrock leaf where the stem is transversus process L4 and with three leaves: electrospine, quadratus lumborum, and psoas muscle. Interestingly, that the point of insertion, the needle, is the same like technique by posterior lumbar plexus. And it is brilliant approach because we can use on this we can see on this same time all very important sonoanatomical structures. We can see the needle, we can see the spreading of local anesthetic, and we can observe how approach for this block we use 25 milliliters of local anesthetic. We can use single shot or continuous lumbar plexus block, and we should perform this block with two steps. First of all, we should identify transversus process, and then we should to do reorientation of the needle for because the needle should pass between two transverse processes. Okay, and the next option for the THA is quadratus lumborum block. Quadratus lumborum block. This is good option. This kind of block we use in the different circumstances in the abdominal side surgeries, in the kind of surgeries, but we use it for the total hip arthroplasty. Unfortunately, the spreading of local anesthetic is not exact mechanism is not known, and we have controversial data about spreading local anesthetic for the types of quadratus lumborum block, but we can use QLB type 1, type 2, and type 3. The very interesting option is QLB1 when we cover iliohypogastric nerve 2, and recently the using of transmuscular block have described. The first report the KGT group where retrospect was published, and in the last issue of Regional Anesthesia and Pain Medicine journal, the prospective published with comparison quadratus lumborum block type 3 and lumbar plexus block. And this is a good study, and this is good news for us, because the author concludes that QLB3 provides non-inferior analgesia compared with lumbar plexus block. But we know that by transmuscular quadratus lumborum block, we can avoid some complications with the same efficacy. The next interesting option is fascia iliaca block. Fascia iliaca block was described in the 80s like anatomical landmarks approach, when he concluded that approach for fascia iliaca block is much better according to sensor and motor block. The main advantage of ultrasound guidance for the fascia iliaca block is that we can visualize all two fascias, fascia lata and fascia iliaca, because blindly we cannot know about sometimes the fascia can fascia lata and fascia iliaca can be together. Sometimes this fascia can be dividing, and blind technique we cannot distinguish where the end point of the needle, and but on the ultrasound screen, we can identify fascia lata and fascia iliaca. And then the next step had been to searching of success to the fascia iliaca compartment block, and some anesthetists claimed that we should change orientation, the needle and point of the needle could be above ligamentum inguinal ligament, and ultrasound guided suprainguinal fascia iliaca was proposed by Australian authors, and I want to show you very interesting study with longitudinal suprainguinal fascia iliaca compartment block. The authors concluded that by this kind of approach, we can block more success nerve 2, because the problem with anatomical lumbar approach fascia iliaca block with classical ultrasound guided fascia iliaca block, the problem was that obturator nerve was blocked very rarely, into 10-15% only. But we know that nerve takes part into innervation of hip joint. And I want to remind you about the probably last option, Peng block. Peng block. This is example of probably the first example of true motor Peng block for dental hip arthroplasty. And during Peng block, we inject local anesthetic between of the pubis bone. What it's give us in the disc compartment, obturator accessor nerve runs, and probably the joint branches of the femoral nerve can run, and injecting local anesthetic in the disc compartment, we can avoid motor block like we did it during lumbar plexus, and selectively block only sensor branches. Then we give 20 milliliters of local anesthetic, and we can observe the spreading of local anesthetic. The similar option is motor sparing block, Ellipsos plain block, but how you can see the orientation of the needle is some different than in the, during pen block. The Danish authors claimed that, but this kind of block, the joint branches of femoral nerves are blocked much, but unfortunately, today we know only cases about using pen block, and we have awaited on the prospective clinical trials about efficacy of pen block or a iliopsoas plain block. What kind of options we can propose for the regional anesthesiologist? We can take into consideration sensor cutaneous branches too. For example, subcutaneous block for the THA has proposed recently, and this is good. This block may be good options, but we need further investigation about efficacy, like addition option for the pen block. For example, for the iliohypogastric block, and which will see how what kind of motor sparing block we can use in the routine clinical practice. Okay, and I want to say some words about erector spine block for the DHA. For example, we can use the same approach for the identification. Anesthetist, some experts claim that we should await on the prospective randomized studies before using erector spine block for the total hip arthroplasty. Much more, we can use adjuvants as a dexamethasone, dexamethomidine for prolongation of our block. And I want to concluding about analgesia of arthroplasty. I want to say that in our hospital we use longitudinal, femoral, fascia iliaca block. We use pen block too. Very rarely we have used lumbar plexus block in the as a post-operative analgesia options. Sometimes we use in our department QLB2 or QLB3. Additionally, we give dexamethasone or dexmedetomidine. Post-operatively, the patient get paracetamol at metamizole and oxycodone orally. Okay, the first part of my presentation is post-operative analgesia for the TKA. We know that arthrotomy is performing in the femoral nerve block of zone innervation. Additionally, we know that femoral nerve branch anterior and anterior medial part of knee joint. Obturator nerve takes part into creating genicular posterior plexus and the branches of sciatic nerve create posterior genicular plexus too. Old strategy, old concept was using femoral nerve block, but unfortunately, by the femoral nerve block, we had met with weakness of quadriceps muscle. And adductor canal block, like a motor sparing block, was proposed, and I would like to remind about the brilliant paper, optimal analgesic block for the TKA, and the experts claimed that and anterior medial part of knee joint, but in the into adductor canal block, this motor branch lies outside adductor canal, and the last conception is to block femoral nerve branches on the femoral triangle level, and recently we have performed femoral triangle block with selective or IPAC block, and in our hospital we use triangle block and plus intermediate cutaneous femoral nerve block plus IPAC block, and we use dexamethasone and dexmedetomidine. When we know that our patient will be problem with very quick mobilization, very quick ambulation, and this patient will be with pain control. We can use femoral nerve block as a single shot with IPAC block, and we use other pain relief drugs as paracetamol, metamizole, and oxycodone. Femoral nerve block we use by classical methods, and we can using femoral triangle block. We should identify the apex of femoral triangle. We can do it with anatomical landmarks when we divide distance between anterior superior iliac spine and base of patella on the half, or we can use some anatomical orienters with medial edge of sartorius muscle and adductor longus muscle, and this point where when this muscle are crossing, this is apex of the femoral triangle, and some centimeters proximally our point of insertion will be identified, and we local anesthetic, some laterally from femoral artery, and additionally we can use the anterior femoral nerve branches for the more succinct the block of intermediate femoral cutaneous nerve may increase of success our block. Okay, and today we know that that obturator nerve block can analgesia, and additionally sometimes we can insert the catheter for the femoral triangle block, and use and give local anesthetic 2 to 3 days with block. What about the pain in posterior capsule? It's a very important topic. we can use sciatic nerve block as a part of quadruple nerve block as a surgical anesthesia. Some anesthetists have used subgluteal as a post-operative analgesia of posterior capsule, but the problems is with weakness of the hamstring muscle and problems and we have had the problems with quick amputation. But when we use sciatic nerve block on the different levels on the thigh, we can use arterial committance as a orientation for identification of sciatic nerve, because this kind of artery runs together sciatic nerve. Okay, we can use more distal approach, for example, lateral popliteal approach, but unfortunately the foot drop out after surgery when will appear, and like good option, IPAC block was proposed. With IPAC block, we inject local anesthetic between posterior knee capsule and popliteal artery when the terminal branches of posterior genicular plexus is running, and these kind of branches are only sensor branches, and then we can avoid for drops and other side effects of sciatic nerve block. Additionally, we should remember that with two and we can find the first randomizing study about analgesic efficacy of adding IPAC block, but some reports have been optimistical. Some study could not find any advantages of this kind of block. We should await on the further investigation about this kind of block. And on the finish, I would like to say that suprainguinal fascia iliaca block is the first choice among different approaches for post-operative analgesia after total hip arthroplasty. Posterior lumbar plexus block is not recommended as a standard standard pain management method for THA. New conception of motor sparing block with bank ellipsos, plain block with adding superior cluneal block can be promising alternative for the classical peripheral nerve block. Further studies are needed to confirm efficacy quadratus lumborum block and erector spine blocks after THA. And motor sparing block have become more popular strategy among different peripheral nerve block for TKA. Femoral triangle block plus IPAC block with adjuvants give good opportunity to realize this concept. Classical femoral nerve block is still missing in some cases. We need further investigations, and this kind of investigations are guaranteed to determine optimal block for the total hip arthroplasty and total knee arthroplasty. Thank you for your attention.
Hello. So thanks for Dr. Tuyakov's excellent speech to share your knowledge about regional anesthesia. So now we have some questions from participants. So welcome Charlie to speak out these questions, and Dr. Tuleyev, please answer these questions. Thank you.
Hello.
Okay. Sorry. Thank you so much, Doctor, for your splendid speech. Just because nowadays THA is very important and very risky for the patient, especially for the LD. I mean, very old patient. And but you provide in your presentation a lot of solutions and options for THA. So there is one doctor who is asking that what's your best recommendation block for THA? Why do you choose that one?
It's very difficult. We don't know what is the best block. It's a concept choice. For example, for the total hip arthroplasty, is suprainguinal fascia iliaca block. When we want to have good pain relief control after, we may use lumbar with caution. We should be carefully.
Mm-hmm.
When we need very fast mobilization of our patient, we can use pen block. This is my point of view on the post-operative management after THA. If if you look on total hip arthroplasty, I think triangle femoral injection plus IPAC block is good concept. When we need good pain control, we may, and we know that that ambulation can will not be very fast. We can use femoral nerve block when we have the young patient. We can use motor sparing block. That's it.
Very good. Very well explained. So it depends on the patient, how old he is, or it depends on how's your motivation. Is it you want to get a pain relief or something? So you said the best one of the best options could be the femoral nerve block and IPAC block combined together. So I think maybe some of the doctors could try that and see how it works later. Okay. So the second question for you is that THA, after THA surgery, the patient has to exercise. They have to move around. So it's very important how they can get pain relief after surgery.
I think motor sparing block, like a pain block, may be good choice, but unfortunately, on today we don't have good evidence. We don't have nice prospective studies about efficacy of pain block. Suprainguinal fascia iliaca block can be good choice, but please remember about probability of falling due to quadriceps muscle weakness.
Yeah. Yes. So you don't recommend to use the continuously catheter injection, like for example, just give a catheter into surrounding of the nerves, and then make continuously every 3 or 4 hours a little bit local anesthesia injection, and then keep it painless. So do you do that in your daily practice for the THA?
Yes, we do. We keep the catheter 2-3 days. We use to ambulate. On the third day, we remove the catheter.
Oh, good. Like 3 to 5 days. You keep the catheter inside of the body, and then after 5 days, finally you pull it out or take it out. Okay. So the next question, the third question is also for you, that a doctor asked, how much dose you will administrate for Shamrock block? As you know, Shamrock block, yes. How much dose do you use?
For Shamrock block by posterior approach, I ultimately 20 milliliters. I rely good study of Axel Soter group. They that demean approximately 20 milliliters.
20 milliliter. Is it a lopecaine or some other local anesthetic?
we used to bupivacaine.
Oh, bupivacaine.
Bupivacaine, yes.
Mm-hmm.
But with using we have reduced the anesthetic during neurostimulation era. We had used 30 milliliters, but at the moment we have used it's okay.
Okay, understand. So we move to the next one. The fourth question is how long you're gonna leave the catheter in for TKA. This is a total knee arthroplasty in purpose of pain relief. So how long you leave? Like I asked you previously for the THA, this is a TKA.
We keep the catheter on the same time. On the third day, we remove catheter when we use femoral block or triangle injection. But recently we have used continuous block some rarely because we have dexmedetomidine which prolong our analgesia.
Okay. So the next question is for the safety of sciatic nerve block. Under sciatic nerve block, so maybe some of the patient is very difficult patient. For example, like obesity patient. So the sciatic nerve is in very deep side of the body of the hip. So how do you solve the implant needle visualization problem? Still you use convex. So how do you solve the problem for the needle tip visualization?
I try to avoid sciatic nerve approach because the distance from skin this transgluteal approach can 12 centimeters. I used subgluteal by subgluteal approach. If we need more proximal subgluteal approach, I perform sacral plexus block like a Mansur approach. Benson sacral plexus convex probe in plain needle physiology. Thomas Benson approach is we need to have we need to block continuous sciatic nerve to the amputation of, and it's my first choice.
Okay,
secondly, I try to decrease the angle during insertion the needle. Yeah, I change yes the opposite probe, and then the angle between probe and needle is changed.
Yeah.
And it gives me much better. It's my way. Okay.
Okay. Yeah. Good. So you tell me a lot about how to maneuver the probes to form the angles to perpendicular to the needle. So that could be much safer. Yeah, definitely. So the next question is for the pediatrics. So do you have any experience for THA in pediatrics use? Any treatment of the THA for the pediatric?
Unfortunately, pediatric regional anesthesia is not my field. Okay. I don't work in the pediatric theater, but from literature we know that for example, fascia iliaca block was by Dallas in the 90s for the first and we can reports about efficacy suprainguinal fascia iliaca block in the and we have the reports about using of block, but we should be early because we have only and for example, if you see if you read on the original anesthesia reports a lot of number of this kind of block for.
Good. So the next one is someone to ask the difference for the conscious number block. There is two approaches. One is posterior and one is lateral. So what's the difference between those two approach?
I think the questioner asked me about differences between the QLB 1 or 2 and type 3. This is a good question. There are controversial data. For example, Danish group with Jens Borglum claims that QLB1 and QLB2 is much better because during quadratus lumborum type 1, we anesthetize additionally iliohypogastric nerve, which innervates the skin of surgical area, and what's very important, the spreading from by QLB1 or QLB2 is much better toward lumbar plexus. But in other hand, there are authors, there are the studies on the cadavers which show that spreading of local anesthetic with transmuscular quadratus block type 3 is better, and for example, the study of American group from Pittsburgh when they revealed that quadratus lumborum 3 is not non-inferior. It's prospective randomized study. But we should await. We should try to investigate this kind of question. Thanks.
Good. So very interesting. There is a doctor from Poland. He asked, could you possibly to deliver a speech in Polish? So, maybe in next week or sometime in the future. So he is very interested in your topic. So so maybe later we can cooperate to also for a Polish lecture for them. All right. So the last one is that if there is a hip necrosis combined with osteoporosis or the bone tumor, can regional anesthesia be used for surgery? So this question asks that if the patient has other, for example, like ears, different ears, like they have bone tumors or osteoporosis, this is very complicated and very difficult for the regional anesthesia operation. So, what's your opinion?
I think regional anesthesia can be used in this kind of circumstances. But we should be cautious. We should keep infection control. We should avoid colonization during our regional anesthesia. About steroids, what about dexamethasone, like a adjuvant with hip necrosis, and using non-steroid drugs as a multimodal pharmacotherapy for pain relief. But very important probably to avoid local infiltration analgesia with bupivacaine, because we know that bupivacaine can lead to the osteochondrotic changes in the hip, in the joints, and it's my answer. under this?
Good question. Good answer. So still there are audience ask questions. So I think time's up, but I still may have one or two questions for you. Continue. Someone, the audience named BJKC asked, can we get your slide? The presentation was awesome. So maybe he can get certification with your signature on the certification. Could be possible. So how was that? How was the slides? Could it be possible for them to have the slide?
There is the question about genicular nerve block for the TKA. This is a good question. This is good approach. This is distal block for the TKA. This is motor sparing block. This is good conception. But I think we can remember about not only about anterior part of knee joint control, and we should remember about posterior capsule knee pain. And second question, what about is about quadratus lumborum block for the hip surgery. I have answered about that. There are different opinions. But for example, my way is if I for example, if I plan to do a posterior lumbar plexus block, and if I have any problems with identification lumbar plexus, I change. I perform transmuscular quadratus lumborum block. When I use when I perform motor sparing block, PENG block, I can add QLB1 for the iliac hypogastric nerve block. And the next question about PENG block plus lateral femoral cutaneous nerve. This is a good question. During PENG block, we should remember to avoid femoral cutaneous nerve injury, because the needle is inside to before PENG block to visualize lateral femoral cutaneous nerve, and then when I after injection injection local anesthetic to the space between pubic bone and psoas tendon. When I remove my needle, I give some milliliters in the near lateral femoral cutaneous nerve in the tunnel, and it's my way. If you have detail, use any other ones. Yes, we use dexmedetomidine, and we use sometimes we use dexamethasone too. Okay.
Excellent. Yes. Very good. So I think all of the questions were asked. So I think time is up also. Thank you so much for Dr. Tuyakov joining our webinar. Have a very profound experience in explaining how we can perform THA and TKA, any no blocks in here. So thank you again, doctor.
Thank you, doctor.
Thank you so much.
Thank you.
So we have to say bye-bye.
Bye-bye.
Thank you, dear colleagues.
Yeah, bye-bye, bye-bye.
And
Bye.
thanks for all participants who joined this webinar and to have communication with Dr. Tuyakov.